Okay, again, we are here today for Preparing for PrEP, Science, Research, and Access. Thank you all for joining us this afternoon. I'll have Sharon Wong get us started.
Hello, everyone, and it wouldn't be a webinar if we didn't have a disclaimer. This webinar is supported by a cooperative agreement funded by the Centers for Disease Control and Prevention. Its contents are solely the responsibility of the authors and do not necessarily represent the official views of the CDC or the Department of Health and Human Services. So as we are proceeding, please use the chat feature through the webinar to type any immediate questions or technical assistance issues that you have that come up. We'll be sure to address them either on the webinar, through the chat feature, or follow up. So again, as you think of questions, please type them in, and that'll help us facilitate the answering of your questions. We have many people who worked on this webinar. Our webinar planning group included Donna Smith, Amanda Brown, Sarah Stolberg, Sandra Leonard, Sharon Wong, Heather Oglesby, Rich Dunville, Susan Adkins, and Stephen Hicks. This webinar is hosted by the Division of HIV/AIDS Prevention, the Division of Adolescent and School Health, the National Coalition of STD Directors, and CAI. Thank you for your questions about how to integrate pre-exposure prophylaxis, or PrEP, into your HIV prevention activities. This webinar is our response to many of your questions. We're very glad that PrEP exists as an effective biomedical tool to help prevent HIV. Today we have excellent speakers who will provide information and guide us through a discussion on the safety and efficacy of PrEP, minor consent laws, experiences of providing PrEP to adolescents in Oakland and Chicago, and examples of how PrEP can be integrated into your existing PS 1308 activities. While PrEP is an exciting new tool for HIV prevention, its availability around the country and clinicians' knowledge about PrEP is extremely variable. This is the current state of affairs in terms of providing PrEP for adults. Providing PrEP for adolescents is much more rare, and clinicians' ability to provide it varies because of state policies around minor consent to HIV prevention. In short, we recognize that people are in very different states of readiness to promote PrEP for HIV prevention, especially to adolescents, and we hope that this webinar gives you some tools and examples that are relevant to your local reality. Let's see. So we'd like you to take a poll to see who's here in this space with us. If you could click on one of the boxes to identify yourself, it would be helpful for us to know the organization that you represent. So please participate in our little poll. We'll give everyone 30 more seconds. Okay, great. Thank you for those of you who have identified other for typing in where your representation is into the chat box. So it looks like we have a number of folks from state and local health departments, as well as school districts, and a lot of community-based organizations as well. Okay. So thank you. So this gives us an idea of who's on the line. Our objectives for today are to learn about PrEP and understand implications for use with adolescents, explore examples of PrEP integration into sexual health education and preventive sexual health services, identify strategies to raise awareness about PrEP among adolescents, and finally to describe factors that influence current PrEP availability for adolescents. So here are some things to keep in mind as we go. So this is some helpful framing. This webinar is being provided to DASH partners to increase your knowledge of PrEP and provide some examples of PrEP implementation from the field. Although trials are underway, no efficacy or safety studies have been published yet on the use of PrEP in individuals younger than 18 years of age. It's expected that once these trials are completed, adolescent-specific recommendations may be developed. Ideal PrEP delivery programs have not been defined for adolescents, and it's reasonable to expect these programs may differ from those that have been used with adults. Adolescents may need more structured support to successfully maintain a PrEP regimen. Adherence may be lower among adolescents, and other aspects, such as the required follow-up intervals, may change compared to adults. As we share information, please keep in mind the DASH strategic imperatives, taking sexual health education to scale nationally, addressing confidentiality protection for teens, especially around sexual health services, expanding the evidence base regarding sexual and gender minority teen health, and integrating substance use prevention into HIV and STD prevention efforts for teens. As we discuss, we'll provide examples of how PrEP will be integrated into sexual health education and sexual health services, and how PrEP can be protective against HIV for sexual and gender minority teens, particularly males who have sex with males. So while you're waiting, and while we're all waiting for adolescent-specific PrEP recommendations, here are some things you can do right now. Include PrEP in ISHE, exemplary sexual health education curricula, so that students know that it exists. Answer students' questions about PrEP. Plan to add PrEP as a component of your referral systems. And think through how to refer students ages 18 or older who are considering PrEP. I'm very happy to get to introduce Donna Smith, Dr. Donna Smith, who is the Biomedical Intervention Activity Lead in the Division of HIV/AIDS Prevention at CDC. Don.
Hello. I'm very excited to be talking to you today about PrEP and what it may imply for adolescents in the U.S., particularly those of school age. First thing to consider when we're thinking about PrEP for adolescents is that adolescents are not a single age group. There are younger adolescents. There are adolescents in sort of the middle age of adolescents who have one particular set of developmental needs. And then there are adolescents who are really young adults, those who are 20 or older. Those who are really young adults are already accessing PrEP, and we'll talk a little bit more about what we know about them later. But those who are sort of in mid-adolescence, those who are 15 to 19, many of them are in school, and you're dealing with them in terms of school health. Those who are in very early adolescence are generally not considered candidates for PrEP at this time, so we really won't be talking much about them. Next. Recently, DASH has done a survey looking at what proportion of high school students in particular are sexual minority youth. This is important because young MSM are particularly at risk for HIV infection, which we'll talk about in a little bit. And what they've been able to show in this early survey is that a substantial but small proportion of high school students, high school young men in particular, either identify as gay or bisexual, or report that they have sex with men. And it's in the order of 2 to 3% of high school students, high school male students. Next slide. And of those who report being gay or bisexual males, many of them report activities which put them in substantial risk of encountering HIV infection. So they may be sexually active and they may not report condom use. Almost half of them report no condom use at their last sexual activity. Next slide. At the same time, when we look at the number of estimated new HIV infections among youth aged 12 to 24 in the United States in 2014, you'll see that of those youth with new HIV infections, the largest group were African American young men, and that was closely followed by Hispanic young men. Most of these were young men who had sex with men. Next slide. When we look geographically at where the lifetime risk of acquiring HIV infection among persons who were uninfected at age 13, you can see that the highest risk of lifetime infection is occurring in the southern states and in the northeast of the United States, and that's followed by the western states and to some extent in the Midwest.
Young people in HIV across the U.S.?
Beg your pardon?
Young people, like risk, the age range, it's like 12 to, or 13 to something. And what's the, do you know the number?
If it's possible, could we hold questions till the end of the presentation? Next slide. So to address these issues, CDC is recommending a whole variety of activities for reducing HIV infections. In addition to the behavior change interventions that we've recommended for a very long time, which includes condom use, sexual behavior change in drug use behaviors that put you at risk of HIV exposure, we recommend, obviously, that people be tested and if they're HIV infected, be treated, both for their own health and to reduce the risk of transmitting to others by reducing viral load, but also post-exposure prophylaxis. And now that we know that it works, the implementation of pre-exposure prophylaxis to protect uninfected people should they become exposed to HIV. Next slide. So PrEP is the daily use of an antiretroviral pill. It's been shown to be a highly effective method to reduce the risk of HIV infection. It was approved by the Food and Drug Administration, and CDC issued guidelines for its use. The pill contains 2 antiretroviral drugs in the same pill, and the pill is sold under the brand name Truvada. Next slide. The way that this pill works is pretty simple. When a person is exposed to HIV, and these examples assume that you're exposed genitally through sex, when you're exposed, the virus enters cells at the site of exposure, and it begins to grow in the cells where exposure occurs. And for the first 2 or 3 days, it grows in those cells locally, makes new copies of itself. And then after the first 2 or 3 days, it spreads through the bloodstream throughout the body and becomes a generalized infection. It's spread to cells throughout the body, and at that point, it becomes a lifelong infection, and it can't be stopped. It can only be treated with lifelong medication. When you take PrEP, what happens is that the drug gets distributed to the cells throughout the body so that it's inside the cells, so that when HIV infects those first few cells at the site of exposure, it can't grow and it can't spread to other cells. And so when your body sheds those few cells that are infected, it doesn't ever spread throughout the body and become an established infection, and therefore you don't have a lifelong infection with HIV. Next slide. So in order to test whether this would work, trials were done throughout the world in several populations at risk for getting HIV infection. Among men who had sex with men, they were explained to them that they would be getting either a pill that had the drug or a pill that had no drug, and they were given condoms and STD treatment and all kinds of other protective methods. When they looked at those who got the drug with the pill with the drug and those who got the pill without the drug, they saw that those who had the pill with the drug had 44% fewer infections than those who had the pill without the drug. In studies with heterosexuals, there were 73% fewer infections. In those who were people who inject drugs, there were 49% fewer infections. But we know that people will tell you they took a pill and they didn't necessarily take it. So they went back and they looked in the blood to see if they could find drug levels of the medication. And when they compared people who actually had drug in their blood compared to those who didn't, in the bars in purple, you'll see that there was much higher protection among those who had drug in their blood compared to those who had no drug in their blood. So there was greater than 90% protection for sexual transmission, and there was 70% protection for those who injected drugs. So what we learned was that the pill is highly effective at blocking infection, and it's especially high if you actually take the pill. Next slide. So after those trials, they then did studies where they actually gave the pill to people and they told them that you're getting the actual drug, and we know that it only works if you take it, and then they watched to see if they were able to take the drug, how well it would work. And among men who had sex with men, what they saw was that people who were able to take it at least 4 pills a week, they saw no infections at all. And similarly, in couples where one partner was HIV infected but was not on treatment, and the negative partner was taking the PrEP pill, again, if they were able to take the pill regularly, there were no infections among the uninfected partners. So we know that there's a certain amount of forgiveness, that if you can take it 4 to 7 days a week, there are absolutely no infections. If you can take it 2 to 3 pills a week, you get some protection, but not as good as if you can take it nearly every day a week. Next slide. Because people are uninfected, it was important to know how safe these pills were. And so they looked very closely for side effects, and there were no serious side effects. Like with most pills, there were some people who got a small amount of stomach upset that lasted a couple of weeks when they started taking the pill, but it went away pretty quickly, and it can be managed easily by over-the-counter medications. There was some concern that one of the drugs in the pill might affect how their kidneys functioned, because this had been seen in HIV-positive people who took these pills. No important changes in renal function were seen in negative people taking this pill. And similarly, there had been some problems seen in positive people taking these pills with the hardness of bones, but no serious problems in bone hardness were seen in negative people taking these pills. So we know that these pills are safe for negative people to take for prevention. Next slide. So based on these findings, CDC issued guidelines for its use in the United States. We made recommendations for how to assess people for risk that's appropriate levels of risk to prescribe PrEP for men who have sex with men, for men and women who are heterosexually active, and for people who inject drugs. We recommend screening for HIV to ensure that people are negative before they start PrEP. These 2 drugs are not adequate treatment for HIV infection, and so we want to be sure that they're actually HIV negative. Among people in the trials who were thought to be negative but were actually early in HIV infection and who started these 2 drugs, many of them actually developed resistant HIV infection. So we also recommend ruling out acute HIV infection before starting people on these drugs and assessing to be sure that people have normal renal function. Once that's determined, then we want people to be prescribed the Truvada pill to take once a day, given no more than a 90-day supply so that they will come back for regular HIV testing to be sure that they're screened for sexually transmitted infections so that they can be treated promptly. If they're women, to be sure that they're tested to see if they've become pregnant, and to continue counseling for to maintain low-risk behaviors, and to test for renal function periodically. We also don't think that PrEP is something that most people will continue for a lifetime, so we ask that at least every year that they be rescreened for their risk behavior to see if PrEP is still something that's indicated for them to continue. Next slide. When we talk about who it is we think is at high enough risk that that PrEP may be indicated for them, for sexual activity, we're generally talking about people who are having sex with a partner they know has HIV infection, particularly if that partner is not on treatment or is not virally suppressed. If they have recent partners who have bacterial STIs, particularly gonorrhea or syphilis. If they have more than one sex partner in the recent past, that they don't know the HIV status of that partner. If they have inconsistent or no condom use, engage in commercial sex work, or in the case of heterosexual men or women, if they're in a very high prevalence area from which they're choosing their sexual partners. For persons who inject drugs, we want to know that they have an HIV positive partner with whom they're injecting, or whether they're sharing injection drug equipment. Next slide. So we've been trying to figure out, trying to understand who's using PrEP right now in the United States. We issued our guidelines in 2014. FDA approved it in 2012. Gilead Sciences, the people who manufacture the drug, have been looking at who's been using it. As you saw in the earlier slides, the risk of HIV infection is not evenly distributed in the population, and in fact it's concentrated among young persons, among persons in the South, and among African American and Hispanic MSM. And yet when we look among young persons in terms of who's using PrEP, you can see that it is concentrated among young white persons, even though the risk of HIV acquisition is concentrated among young Black and Hispanic persons. Next slide. When we think about how we might want to deliver PrEP to young school-aged persons who may be at risk for HIV infection, delivering it in school settings may be particularly appropriate. It's a place where you can individualize care, where you're seeing both younger and older adolescents, where you have school health. You may be in a place where you can safely disclose behaviors in a confidential setting, and you can provide support for adherent use. You may be able to provide socially appropriate health care and access to health services. There are issues, however, about autonomous consent to services, particularly for younger adolescents. There are places in the United States where this is a legal and regulatory problem. There are issues about insurance and explanation of benefits when you're talking about minor youth, and protecting the confidentiality of services for younger youth. Where youth are reporting sexual behaviors and other behaviors that may place them at risk of harm, there are reporting issues because Many healthcare providers and social service providers are responsible for reporting such issues to appropriate authorities. Access to social services is something that can be provided for school-age youth, particularly in school health settings, through various kinds of referrals. There are issues about housing services, particularly for out-of-school youth, and other issues of safety for some of, particularly the socially disadvantaged youth, who may be particularly appropriate for PrEP. Next slide. The other issue that's PrEP specific has to do with, we talked about the importance of taking the drug regularly in order to achieve protection. And yet in the studies with young adults, what we're finding is that adherence to the medication is a particular problem. So in this study where they looked at 18 to 24-year-olds, so in the older adolescents, what they found was that when they saw them for monthly visits, they had reasonable adherence. The dotted line shows about 4 doses a week, 4 or more doses a week, which is what you would like to see. And when they went to quarterly visits, which is what's recommended in the guidelines, seeing people every 3 months, adherence fell off for some of the young people, especially for the African American youth. Next slide. And when they looked in the study of 15 to 17-year-old youth, that was even more problematic. It fell off for all of the youth when they went to quarterly visits. Again, you can imagine that in a school health setting, it would be much easier to see people at regular intervals to support adherence than in a community setting. Next slide. We were talking a little bit about consenting autonomously to services. In most places in the country, consenting to STI services is possible at young ages in most places. However, PrEP is not an STI service. It is a clinical treatment, and they're a preventive service. And there are really only 3 or 4 places in the country where minors can autonomously consent to preventive health care. And so it will be important for each place to know what the rules are in their jurisdiction and at what age youth can autonomously consent to STI to PrEP-like services. Even though it's HIV, the rules are different for HIV testing, for HIV treatment, and for a preventive service like PrEP. Next slide. In addition, paying for PrEP is complex since many young people don't have their own insurance. They may have insurance through their parents. Some of the resources that are available to get free medication are not available to young people because it is an off-label use of PrEP. It's not approved by FDA for people under the age of 18. So paying for PrEP can be very complex, and I think some of the other speakers are going to talk about that. Next slide. For providers who have never provided PrEP before and who need a little hand-holding, CDC funds something called the PrEP line, where a provider can call and get clinical advice about how to provide PrEP, how to pay for PrEP, what some of the resources are. And so this is a resource for you if you need advice about providing PrEP and you've never done it before. Next slide. So thank you very much, and I think we're going to do questions at the end, if I remember, so I'll turn it over now to one of the next providers who's going to talk to you.
Thank you so much, Dawn. This is Sarah again. Thank you for your presentation. Just a reminder to everyone that if you have questions while our presenters are talking, please feel free to type them into the chat box, and we're keeping a queue of them for the end when we'll have plenty of time to address all the questions. So now we're going to move on to some experiences from the field. So we're pleased to have Cassie Warren from the Howard Brown Health Center in Chicago join us. Cassie, are you there?
Yes. Can y'all hear me?
Great. Yes.
Awesome.
Thank you all so much for inviting me to join the call. I'm excited to talk with you all today. I got about 5 minutes, so I'm going to go over some things really quickly, and then hopefully we can get into some things in Q&A if folks have follow-up questions. Next slide, please. So I work at the Broadway Youth Center, which is a program in Chicago. We provide services to LGBTQ young folks experiencing homelessness or housing instability. And we are primarily a social services program to provide basic needs. But we also started to provide auxiliary programs to add additional services to those. In the past couple of years, we were able to add primary care as one of those resources that evolved out of our HIV and STI walk-in testing center so that primary care services could focus on sexual and reproductive health and also be easier to access for young people through like a walk-in model. Next slide, please. So it is a walk-in model. In addition to that, we do same-day PrEP, and we also have dedicated staff to help with medication assistance and things at the pharmacy. So a lot of what Don mentioned around a lot of barriers that come up for young people, in particular around insurance, can be really challenging. And we've come up with some really creative solutions at our clinic, and that has been really helpful to have a full-time staff dedicated to being able to help people navigate those. I've also, myself and Caitlin Cunningham have created a guide for people who may not have like the budget or staffing to have a staff person specifically dedicated to that. And it goes through all the steps to help folks with that. And that can be found on Hive's website, but people can also email me afterwards if they want to know where that is. And we created that because we know a lot of folks might be talking to people about PrEP and then may get stuck at the, well, how do I get it part, or what if this problem is happening. And so we made a guide that could easily walk folks through, and you can sort of self-teach anyone how to help young people get through that process. Not necessarily young people, but so anyone. Next slide, please. So I wanted to mostly focus today on not necessarily what PrEP looks like at our clinic, but the relationship that we developed with the Chicago Public School System to reach a more variety of age ranges. So we work with folks who are 12 to 24, but we see a lot of people who are sort of in that like 19 to 24 range, and to try to start reaching out to other young folks in Chicago, we went through and started in 2015. The staff went through a training at CPS for sexual health education for their students. And we realized that PrEP and PEP were both missing from the training. And CPS has an official way that you can submit curriculum feedback, and the staff that work in the department around the sexual health education are really super supportive and passionate, and they took that feedback very seriously. And so starting in 2016, they were able to implement PrEP and PEP into the training. So the CPS gives trainings to their teachers, but also to other community organizations that have staff that are already really dedicated and excited about talking to young people about sexual health and consensual relationships and things like that. So our staff went through the training, which means we can train other staff as well as give the trainings within CPS to young people. There's a lot of processes for the review process. I could go through that later if folks have questions about those specific processes. And then some of the areas of growth that we're seeing and looking for are sort of fleshing out the definition of how HIV is being defined within that training. Also, even though PrEP and PEP are mentioned, treatment options aren't mentioned within the training. So I think that's an area of like growth that we can all really dive into and figure out ways to talk with young people about that. And then another area for growth is, the assessment of once you go through the training process, the assessment for trainers is really around a lot of the legal stuff and not necessarily about like how you might be presenting some of the content. So I think it's really important with young people that we figure out on our own how to develop our own sort of like elevator speeches around PrEP and PEP and treatment to figure out how we want to really dive into a lot of the areas that we're talking to young folks about their sexual health or healthy relationships. And I believe that concludes everything for my slides.
Thank you so much, Kathy. That was great. We are going to move to another from the field presentation with Dr. Tomas Meghana, who is an assistant professor at Samuel Merritt University, attending physician at La Clinica de la Raza, assistant clinical professor in the Department of Pediatrics at the University of California, San Francisco, and the founding director of Faces for the Future Coalition. And he is based in Oakland, California. Tomas, are you there?
Yes, I am.
Great. Take it away.
Thank you. Can we move to the next slide? Let me see if I can do that. Yes, hello everybody. I'm delighted to be here and talk a little bit about our experience in our particular youth center with regard to implementing PrEP services. In terms of background, as mentioned, I am a pediatrician and adolescent health provider. I've been practicing for approximately 20 years in a very at-risk, high-risk areas of Northern California, Alameda County. I work within a school-based health center practice, which is located within which is part of a large regional safety net community health center. So we are considered really a safety net practice for a large community. And our particular clinic serves a very diverse adolescent population, age 11 to 24, primarily African American and Latino, large immigrant population, newly arrived, and actually a large population of sexually exploited minors as well. So our interventions really have to be catered and customized according to the particular needs of those communities. We serve a very largely uninsured or underinsured population, which means that they've had poor access to care for several years, and as such suffer from some of the highest disparities, particularly with regard to reproductive health issues. And we do serve not only as a primary care center, but we also serve as a behavioral health and a reproductive health home for many of the young people we serve. And what that means is that even if a young person can identify a primary care provider or a primary care clinic elsewhere, if they do not feel comfortable accessing reproductive health services, meaning birth control, STI infections, or PrEP, they can come to us confidentially and without concerns for payment. As I mentioned, we do serve a very at-risk population, so there are significant health disparities we have to address. And a part of the nature of being obviously a pediatric practice and an adolescent practice is there's a wide spectrum of cognitive developmental stages in a young person that Dr. Smith actually referred to. Early in adolescence, young people think very concretely and gauge risk very differently than an older population of young kids. So if we're going to really talk about prevention and risk categories, we really have to understand where a young person sits developmentally and what they perceive as risk to themselves. And then the other piece, of course, with regard to working with children and adolescents in particular, is they have very unique values. Specifically, confidentiality is of key importance when addressing any kind of healthcare service with them. And there are also huge concerns about parental and informing parents about receiving these services as well. Historically, we generally have had an underutilization of reproductive health services in our department, and we wanted to better understand why that was happening. So we did a survey of about 50 young people in our catch area, essentially asking them why. And the two things that came out that they identified as perceived barriers and to some extent structural barriers were, number one, concerns about confidentiality, and number two, a great deal of ignorance. Young people simply didn't know what was available to them, and they did not have any sense of what the laws were that protected them around confidentiality. So with regard to the implementation of PrEP services in our particular clinic, what we had been doing historically, and what many pediatric and adolescent health practices actually do, is that any young person, minor or young adult, who had been identified at risk for HIV infection was actually referred to external resources in our community. That was pretty much the standard. Now, we realized and we soon determined that referrals to those external agencies were ineffective. And in fact, what prompted me to consider changing the way we practiced was as I actually had a young man who was very high risk, MSM, multiple partners, a lot of psychosocial concerns. I referred him to our local department that I knew provided PrEP in a very safe and confidential manner. He ultimately refused to go for a number of different reasons, lack of trust, other access issues which he perceived, and ended up becoming infected. So we knew that that referral outside was really an effective mode to prevent transmission. The other piece of this is that we were consistently aware that because we are dealing with a very at-risk population, we have to provide services that are more comprehensive in our clinic, and that we're dealing with a population that is particularly at risk, particularly the sexually exploited minors. And because there's a great deal of poverty in our community, we determined and we knew that there was a group of young people that were actually engaging in sexual activity for payment in order to meet bottom line, even though that they didn't identify themselves as bisexual or heterosexual or homosexual. So when we were really looking at about how we would begin the provision of PrEP in our clinic, we had to really look at the flow of care within our agency and really understand where the points of barriers, both perceived and structural, existed within the perspective of the young people we served. And if you look at this particular flow chart, you can see that there are multiple levels that determine access. Number one, a patient expresses a concern or demonstrates a concern that puts them at high risk. The first point of barriers may be just entering, getting that appointment, okay? The second level of flow of care would be not only making that appointment, but actually then receiving the services, following up and actually receiving the medical services. And then obviously the last, hopefully, outcome that we get is that they actually result in a positive health outcome. So the boxes at the left kind of point out the barriers that we determined were prevalent in our particular institution. And so with regard to the first level, we really had to address the issues of ignorance, meaning young people did not know what PrEP was. They did not really understand what put them at risk, and they really didn't understand the notion of confidentiality and privacy, two main concerns that young people have expressed as potential barriers. So in response, we created services, peer health education services that talked about PrEP and talked about confidentiality and privacy. And we did a lot of outreach to not only identify ourselves as a PrEP provider in the community, but also a safe place for young people to come that really honored confidentiality and privacy. That would at least get them to make the appointments and enter our clinic. The next level then was really actually getting the services themselves, the provision, and obviously one of the main barriers is how do you pay for it? There are certain programs that we can enroll young people, state-funded programs like Family Pack that do guarantee payment for reproductive health services or Medi-Cal minor consent that young people are eligible for, and just the process of enrolling them is one step. But we also do a good job at informing young people about what their consumer rights are with regard to confidentiality. And then, of course, there are programs that do pay for PrEP offered by Gilead, the company itself, that we will actually enroll young people in to ensure that they get the service and the medication. Then there's actually the provision of the service itself. And as I said, we have to orient our approach to the developmental placement where that young person is to understand what they perceive as risk and really talk about that in terms that they understand. But we also have to understand the psychosocial issues that are impacting our young person, community violence, poverty, family dysfunction. Those are all potential barriers for a young person to comply and to adhere with medication and to follow up. So that is part of our regular adolescent health assessment for every young person that comes in to really gauge and understand where they see challenges lie and then refer appropriately because we are a multidisciplinary team. So if they require behavioral health services or social services, we will do that. If they require insurance enrollment, we will do that. And integrate PrEP within the context of primary care. It does not become a separate thing. It becomes part of primary care behavioral health services, which then can help reduce stigma. And we know that stigma is a huge issue for many of our young people. There are tremendous cultural as well as developmental issues that prevent our young people from either identifying behaviors that put them at risk or actually seeking services. We serve, as I said, a very large African American and Latino community, particularly large immigrant, and there's a huge reluctance to disclose behaviors that would identify them at risk. So we really have to address that notion of stigma, really understand the cultural issues that relate to discrimination and so forth, and address those in the delivery of our services. And then lastly, as I said, rather than refer out externally to receive PrEP, we've now implemented it within the context of our care. So opportunities for collaboration really, my recommendations really come as a result of the lessons we've learned. And I encourage folks to really work with your local healthcare partners to, number one, really empower you to become informed healthcare consumers. They really have to understand what their rights are with regard to confidentiality and privacy, and we know that those differ between states, and that makes a huge issue. We have to inform students about local resources because ignorance, remember, was the number one barrier, number two barrier that students summarized in our survey. And so young people don't even know where to begin to ask the questions, let alone receive the services. Please include PrEP in health education. It has historically been absent. Whether it be peer health educators or adult health educators, PrEP has been rarely included. And we've begun to include that in our health education efforts. And it's made a big difference in terms of addressing ignorance. I've talked a little bit about addressing stigma and biases, and there's a number of ways that can be done, not necessarily always focusing specifically on PrEP, but really the notion of sexuality and how young people feel comfortable talking about their concerns and issues with regard to sexuality. And then, of course, to advocate for on-site services, reduce the barriers of having to young people be referred elsewhere or go long distances to try to get information or questions. So in a quick nutshell, that's pretty much what I wanted to share.
Thank you so much. And again, if folks have questions for any of our presenters, please type them in and we can direct them to the appropriate presenter at the end of this webinar, and we'll have plenty of time for questions. So with that, I'm going to move into talking a little bit more about messaging and awareness and raising awareness among our adolescent populations and among those who work with them, which are many of you on the line today. And I am Sarah Stahlberg. I'm with the National Coalition of STD Directors, where I work with state education agencies primarily on facilitating access to sexual health services for adolescents. So partners can begin preparing for PrEP with young people by doing a few things. Being able to answer student questions, which is something that Dr. Meghana just highlighted, including mention of PrEP in sexual health education curricula, planning to add PrEP as a component of sexual health referral systems in the future, or as you're developing it, and understanding that there might be adolescents under the age of 18 who are candidates for PrEP based on careful evaluation by their healthcare provider. Given the prevalence of STDs among adolescents especially, it's important to remember that while PrEP protects against HIV, it does not prevent STDs, sexually transmitted diseases. But condoms can. Correct and consistent condom use can. When taken every day, again, PrEP provides a high level of protection against HIV, especially when combined with condoms. And so messaging to adolescents should include a dual protection approach. We know that condom availability programs, which can be school-based or within the community or within the public health infrastructure, can support program implementation and messaging around PrEP for adolescents and represent a strong opportunity for collaboration between HIV and STD prevention efforts. So this little image in the corner, the condoms still work, represents my organization, the National Coalition of STD Directors' ongoing partnership with Trojan through our Condoms Still Work initiative. This provides member health departments with free condom donations. I should note that while we are not aware of any current marketing strategies, including Condoms Still Work, that have been developed and tested specifically for adolescent audiences in the context of PrEP. So what are our key takeaway messages this afternoon? Ideal PrEP delivery programs for adolescents have not yet been identified, but we can expect some key differences in that audience, including more structured support to successfully maintain a regimen, strategies to help ensure medication adherence, and more frequent follow-up intervals. It's important to note again that there are no published safety data currently available for HIV uninfected use, and starting to collaborate with community efforts in educating both parents and adolescents will provide an infrastructure to implement HIV prevention interventions and to create positive structural change within communities to lower rates of HIV infection. Finally, I should again emphasize that PrEP does not protect against STDs, which is important to consider when working with this younger adolescent population, which again reports high rates of STDs nationally. And with that, I want to open it up for questions. You can type in your question using the chat feature, and if you can, identify to whom your question is directed. And if we do not get to all of the questions in our time together this afternoon, you will be receiving, again, these slides at the end, which will include all presenter contact information. So I will read the questions out loud and then direct to the appropriate person. So let's see. We did have one question. I think this is for Dawn. Did partners have low viral loads, and is that a confounding variable?
No, in the partner study that was done in a country where HIV-positive partners had to be eligible for treatment by having a low CD4 count, and so couples were enrolled in which the positive partner did not meet the eligibility criteria for treatment. So none of the positive partners were eligible for treatment and therefore did not have a low viral load.
Thank you, Dawn. We have, can PrEP be used or taken as a one-time treatment option in the short term, ideally for somebody who was raped and may have been exposed? If so, how long would he or she have to take the treatment?
Dawn.
Who do you want to answer that?
That could either be you or Dr. Meghana, whoever has the answer.
Dr. Smith, go for it.
No, PrEP is for people who have ongoing exposures. For a person who had a single exposure, we recommend post-exposure prophylaxis. That would be if somebody comes in within 3 days, within 72 hours of a single exposure, they would be started on 3 drugs, and they would stay on those drugs for a month, for 4 weeks, and then they would be done.
Great, thank you. All right, we have, what if a student is questioning or unsure about their orientation and therefore their risk level and need for PrEP? Cassie, do you want to take that one?
Yes. Wait, am I unmuted? Can everybody hear me?
No, we can hear you.
Oh, sorry. Okay. My phone cut out just a little bit. Could you repeat the question?
Oh, sure. What if a student is questioning or unsure about their orientation and therefore their risk level and need for PrEP?
Yeah. I think it's great with young people. I think it depends on where you're at in your relationship, with that person. So I would say that if you're still like in the part of like developing a stronger relationship with a young person, that I would just like really affirm how they're feeling, and then just provide like things about facts in terms of risk. If there's stuff that you don't know, I think it's great to be like real about that, and then tell them that you'll make sure you protect their privacy, and that you'll make sure you get an answer that is like a fact if you need to check in with a nurse or something like that. And I think you could ask people like in terms of like their sexuality and orientation, what things that they I think it's best not to make assumptions because everybody's bodies are different, and identity can be just because I might identify as a genderqueer person or even as a lesbian, it doesn't mean that I might not also as a lesbian have sex with other trans women who also identify as being lesbians. So I think not making assumptions about their partner's bodies and probably asking specific questions about what types of sex they might be interested in having, because the risk varies on what those things are, in addition to what techniques or prevention methods they might want to use depending on the specifics. So I think it would be good to affirm, to not make assumptions about people's bodies or what they might want to do with their own bodies or with somebody else's bodies, and just sort of ask them those types of questions to sort of get at that type of thing. Is that helpful?
Thank you. Do our other presenters have additional responses?
No, I agree 100% with that. I think at times, particularly in early to middle adolescence, you have to really differentiate between how a young person, quote unquote, identifies versus the actual behaviors they are engaging in. There's not always concordancy in their perspective of a match. There's a lot of experimentation going on, clearly in adolescence, particularly around this particular generation, around gender fluidity and sexual fluidity and so forth. So the types of labels that we kind of have historically been put on, young people are beginning to think through a different lens. So in particular with regard to my practice, I focus very concretely and very specifically on actual behaviors. What are they engaging in, right? And then from there can have certainly a conversation about identification and so on and so forth, and concerns around identity. Because as I've mentioned before, huge cultural cues and issues related to how a young person identifies.
Thank you. Our next question, I think, Dr. Smith, this is for you. Do we know if the use of PrEP reduces further HIV transmission from the exposed individual during the initial treatment phase?
I'm not sure I understand that question. If you don't have HIV infection and you're taking PrEP, then you don't have any virus to transmit to other people. So I don't understand the question.
Okay. If Denise, who typed in that question, if you want to send a clarification and we can revisit that question. I'll move on to the next one in the meantime. This is a long one from Tim in LA, who says that we did several focus groups of young men of color in our priority schools and found much of the same. When asked about STDs and HIV, they felt like it was not important to them or their friends. They felt invincible. They felt going to a clinic was the walk of shame and did not want to go. So we've done youth leadership summits and a provider fair focused on LGBT providers to introduce our youth to them and to make them feel comfortable. Have other folks used this, or are there other best practices as well that you know of? I guess this can be for anybody.
You know, one thing I would say is that if we're not trying to talk people into taking PrEP, and if we think people are at risk and they don't think they're at risk, they shouldn't get PrEP because they're not going to take it, they're not going to adhere to it. So I think on the one hand, we do want people to understand their risk, but I think PrEP is not something that we're trying to convince people about. So I think it is important to try to work with people to get them to understand what risks they're taking. But I think that's a separate discussion than whether we want them to take PrEP.
Thank you. Others?
Yeah, I have a few thoughts. I definitely understand that. We have all kind of come across that notion of invincibility. What I can say is that in my own experience, what young people articulate kind of in the public setting or in the out-of-clinic setting with regards to invincibility does not necessarily reflect their true views or perceptions. That when we have got them actually into the clinic and have had the one-on-one dialogue presented in a way that perhaps is less threatening, that notion of invincibility seems to dissipate a bit, and they're actually a lot more perceptive about it. But again, they follow up on the social cues from their peers and what is going on in the school in terms of that. Now, again, yes, this is developmentally based, and we see that invincibility, quote-unquote, wane a little bit as young people get older. But I think we have to kind of reframe the situation in which PrEP information is offered. If it is in the context of encouraging a young man of color to go to the clinic to learn about STDs and how to avoid HIV, yes, it's a very different dialogue and probably a different receptivity. However, if we include that same information in dialogue within the context of a primary care situation, say a sports physical, where every young man will likely come in because they want to be cleared for sports, or information, during, an asthma visit or whatever, if we include it consistently, simply as part of our anticipatory guidance, right? Not only at times when we deem them as risk, but really normalize it as part of an anticipatory guidance, it then tends to normalize the situation, and young people may be a little bit more receptive and see it less as a stigma. And so that's in practice what we've begun to do, not just to reserve information about PrEP at times when they're coming in for STI checks or information about STIs, but rather at times when they would probably least expect it, such as a sports physical. And so that seems to have done had some benefit in kind of changing the perspective of young people with regard to it in our institution.
Thank you. Cassie, do you have anything that you would add?
No, I agree with what's been said.
Great. So our next question is a little bit more general. So I don't know who would be best to answer this, but how are certain agencies meeting the costs of providing PrEP out of their facilities? Is it through grants, donations, or is it being built into the facility budget for prevention?
This is Cassie. I can talk a little bit about what I know in terms of like the cost of PrEP, and from sort of an operational perspective. There's a couple things you can look at. One, you can think about the cost of PrEP in terms of like staffing, and there's some ways that you can get creative about that I mentioned before. Like you don't necessarily have to have a specific person. If you could train other folks who are most likely to have those conversations with young people. And then the cost of PrEP in terms of like the drug itself. And the way I explain it to young people is that there's the cost for being in the clinic, the time with the provider, and the cost of your lab work. And then there's the cost of the medication. And in terms of your operations, you're not paying for any of the cost of the medication, so you're just thinking about the support staff that it takes in the lab work to be able to do that. And I know there's certainly different grants. The lab work for PrEP is we have everybody tested for HIV as well as all STIs. And that's like not just peeing in a cup, but doing an oral swab, an anal swab, a vaginal swab, or peeing in a cup, as well as blood draws for syphilis and an HIV confirmatory, and then doing like a rapid HIV test that day. And then there's like some metabolic paneling. So there is a lot of lab work associated with it. For all of the testing, we do have some grants through the city to cover it, but for everything else, our agency picks up the cost of that. We are a federally qualified health center, which means that it is our mission to provide care to people regardless of what they're able to pay for. And I'm not really a part of the committee that decides like how those things are possible or like where the money comes from. So I think it's a combination of working with the city for testing, and then just figuring out where things come from in the other budget. I don't know if that's helpful.
Thank you. Do others have responses?
Yeah, this is Tomas. It's very similar approach to us because there's multiple levels of complexity with regard to PrEP, the educational piece, right, the lab work piece, and then the actual visit, and then the medication. We divide up those costs according to what we can. So obviously, for us, it falls within reproductive health services, and we will automatically enroll any young person who is either uninsured or does not feel comfortable going to their primary care provider in a program we call Family Pack, which is a state-sponsored program for reproductive health services. Now, again, that will allow for STI testing, which includes HIV testing, to do that baseline. If there are, for additional, the other metabolic studies, if patients have insurance, we will cover it. It will be covered under that. But for the most part, we have a very large uncompensated care portion, and we will just cover the costs through grants that are gained through our organization. The challenge, of course, is that because it is off-label, the biggest challenge for us is really accessing the medication. And for those who do qualify, meaning 18 and over, for where it is approved, if they do not have insurance, I will enroll them in the Gilead program that will cover the costs and submit the paperwork on their behalf. Or I will enroll them in the co-payment assistance program if there's a large co-payment that they cannot cover. But again, that is limited to those for where it is approved for. For the younger ones, we're still trying to figure out the best way to get that coverage.
Thank you. Okay, so our next question is, the age of sexual debut in LGBTQ youth is on average much younger than what we see in hetero youth. Is PrEP being discussed in middle schools and or with very young adolescents, ages 11 to 13? This question is probably for Cassie or Dr. Meghana.
That's a great question, and in my opinion, it absolutely should be. It absolutely should be. We are seeing sexual debuts among many of our youth starting as early as, I hate to say it, but 8 to 10 years old. Now, obviously, we have to be concerned around the exploitation and decision making and all of that. That's the implications of all of that. But in terms of anything related to reproductive health, we absolutely have to begin discussion and information as early as possible. So because we do see young people starting at 11 years old, the discussion around PrEP, just as a preventative, just as we would have a discussion around condom use, right, or birth control, whether or not they are actually have had their sexual debuts or not, it's part of the anticipatory guidance process that we have deemed as a value in our clinic. So yes, I am discussing it in children in middle school and younger, to the extent that I feel it is developmentally appropriate, of course.
Yeah, I would just second that.
Thank you. Let me see. I have a few more questions coming in here for you all. Tim in California, again, said, in California we have PrEP that's now required to be taught in middle school and high school. Oh, so to continue responding to this question, under the umbrella of biomedical interventions, the governor also just signed legislation around PrEP today to make sure that more of this is happening.
Wow,
so
great.
There we go. California's doing great things.
I'm glad to know that.
So that's actually it for the questions that I have so far. If anybody else has questions, please type them in, and we have plenty of time to answer them. I'm also going to put all of our contact information up on the screen here. We can sit tight for a moment while you ponder over some more questions. And to fill the dead air, I will remind you all to please complete the evaluation that you will be directed to immediately upon closing the webinar. It's really important to us to hear some feedback about today's content and what you'd look for in the future. Well, not seeing any questions coming in, so I want to thank you all for participating today, and especially a huge thanks to our presenters for sharing their expertise and their experiences from the field. I hope that all of our attendees learned as much as I did as the kind of facilitator here. And please reach out to us if you have any questions. You will receive an email with the slides and with a resource sheet that was developed by the CDC. So you can just feel free to reach out with us and have an ongoing conversation. For those of you that are state education agencies, you can reach out directly to me. Local education agencies, Amanda Brown at CAI. And if you're an NCSB member, you can reach out to my colleague Stephen Hicks with questions. And then you'll see the CDC contacts and our field implementer information on the screen as well. So thank you all. Have a great rest of the afternoon.
Thank you.
Thank you.